All right. Apparently, some files were maybe broken. As you see here, the slide shows some kind of disarrangement of certain these characters. Now, this slide I showed the last time. In this female, you can see breast cancer is more common than any other type, and also is slowly rising in incidence. Yeah. And you can see here, last year, the statistics shows more than 300,000 new breast cancers. And almost all of them were invasive breast cancer, invasive. So very small portion, show non-invasive breast cancer. This is called very early stage ductal carcinoma in situ. So majority is invasive breast cancer. And it's increasing, as I said. And while in the Western, particularly United States, still around 50 or over most common, but in Korea somehow, at a young age, 20, 30, very popular. And when we diagnose, about 60% are limited in local place. And this just an incidental finding by a routine mammogram or ultrasound, and then 20% is regional, so one breast, that area. But 5% are already metastasis from the beginning of diagnosis. Now this, about 10% are dying with breast cancer, but this mortality has been decreasing since 1990. There are many new therapies. So just like prostate cancer, it's generally about 60, 70% are controllable, good cancer. And the other is unfortunately bad, because we are diagnosed in relatively early by routine mammogram, and then certain more recently all tomosynthesis, or at least a digital mammogram, which is much easier to interpret by radiologists. Now, estrogen, as you know, is just like androgen, is a steroid hormone. It's producing mainly by ovary, but some adrenal glands and certain fatty tissues. And certainly male, female all have estrogen, but obviously a lot more in female. So male also have a female hormone, and then female also have a male hormone. But in female, after menopause, this estrogen, female hormone, is almost gone. But in male, even after menopause, the testosterone become less, but it's not disappeared. Until male died, there's a continuous sum remaining. Okay, obviously this estrogen hormone is functioning in sex and reproduction, but also this estrogen important in brain function. That's why we see a lot more common dementia in female. After they become old, they don't have, unless they replace some minimal dose estrogen, they develop some functional problem, cognition functional problem in the brain. Obviously, bone is continuous remodeling by balance of osteoblast and osteoclast that require estrogen. So a lot of females develop a lot more bone problem like weakness and arthritis, etc. And also estrogen is important in cardiovascular function, maintaining cardiovascular function. So that's why many American endocrine gynecologists recommend a lower dose of estrogen or estrogen combining progesterone after menopause to maintain their health in this cognitive function, bone and cardiovascular function beside the sexual function. But in Korea, a lot of ladies are reluctant to have estrogen after menopause because they worried about developing uterine cancers. But uterine cancer is as a complication. It's certainly a concern. That's why it's a low dose and sometimes combining with the progesterone, which makes a less instance. But in United States, most ladies over age of 30 do not have a uterus. After they have babies, they usually remove. They receive hysterectomy. If there is any fibroid, any tumor, they just remove. So they don't have to worry about developing cancer in the uterus. That's the one lesion. And also uterine cancer, cervical cancer, is easy to detect by pap smear. And also since they have a bleeding, it's easy to recognize. And also just a hysterectomy is an answer for early diagnosis, early stage of uterine cancer. So it's not a big deal. So I think you have to maybe educate ladies to receive some low dose estrogen or combining estrogen with progesterone. This estrogen stimulate the follicles in ovary, and then also like a lubrication in vagina for sexual intercourse, and then certainly secreted the mucus in the uterus for pregnancy, and also stimulating breast for milking. So these are the all main functions. Now, as I mentioned earlier, there was a report of estrogen may decrease instance of colorectal cancer in 30%. So this has to be continuously studied more and more. So if there is an imbalance, underutilization or overutilization, all those cause certain clinical symptoms. And then certainly hot flash and night sweating, and then some breast or uterine lump, and some depression, anxiety, fatigueness. Insomnia is also important, related to estrogen. And certainly weight gain, dry skin, etc. So all menopausal ladies experience this kind of things because of less estrogen. Now, just like any other hormone, there's a feedback system. The hypothalamus, stimulating pituitary, and the follicular stimulating hormone, lutein hormone, and that's all stimulating ovary to produce estrogen. And the there was a report of this estrogen effect on the seizure. So that's another thing. People, why certain patient develop the seizure, and a lot of causes certainly should be ruled out in the brain, inflammation, tumor, etc. But if somebody doesn't have enough estrogen, that also makes some kind of electrical sort of signals by certain malfunctioning brain cells. Now, there are 3 types of estrogen. Most common estradiol. So this is related to, as I just mentioned, all clinical symptoms. But if you take more than necessary, uterine cancer develop. And certainly some breast cancer develop also. Estrone usually secreted are more after menopause. And this estrol is usually secreted during pregnancy. The chemistry is similar, but a little different. As you see here, this is a menstrual cycle, initial follicular phase here. So estradiol is rising and then down. And the later is a progesterone. Progesterone is in the luteal phase, not follicular phase. And so there's this difference in amount in cycling. So when they measured from blood things, they have to know what time period they are taking. Now, you probably heard that a lot of phytoestrogen, this soy and berries, nuts, is all good, fruits, wine, they contain estrogen, some substances. So that's why a lot of patients ask whether they should take this kind of things or not. And certain this supplement as well, red clover, some this certain milk, other things. So but they contain but very, very small amount. And also our body always trying to make homeostasis. When you eat a lot more berries, things, there are some, but absorption and utilization is controlled by our body self. So certainly excessive drinking red wine, things, certainly should be avoided in breast cancer patient or any ladies because of that. But just a social drink things, it doesn't make any significant impact. That's what the experts usually say. Now, progestin is usually from ovarian corpus luteum, and this function is mainly growth of endometrial vessels and glands for placenta, for pregnancy. Most endocrine gynecologists prescribe 0.025 milligram estrogen plus minus 2.5 milligram progestin for hormonal replacement therapy in ladies after menopause. Now, breastfeeding has been well known with lots of benefits, including reduced infant mortality, less infectious diseases, and obviously boosting infants' immune system. and also even less risk of diabetes, and obviously enhanced brain function. This has to be emphasized because a lot of young ladies try to make an excuse to avoid breastfeeding, their body shape or walking, many other things. But if they want to have a baby, they should try to make a breastfeeding with a lot of benefits. Particularly this brain function, psychological, other things are not here, but a lot of people talk about that. Now, as you know, just like any other cancer, normal tissue slowly become degenerated or changes by a lot of factors. That's called hyperplasia. Just the cells are more proliferating. And then there's a atypical hyperplasia. This is the sort of a suggestion of developing cancer. And then first stage In-Situ. It's ductal adenocarcinoma In-Situ. And then once they break cell membrane, it goes outside to the lymphatic system and go to the lung. Once the lung metastasis cannot be controlled, then go to bone. Just like a prostate cancer, breast cancer has a tendency to go to bone frequently. Why? A certain genetic explanation has been made. So this, but during this slow progression from a normal to cancer, there's a lot of genetic factors are involved. So many. You can see BRCA1, BRCA2. That's usually bad gene, and the famous actress, as you know, had this gene and removed both breasts. And also when I was in MD Anderson, we had also some embarrassment by certain young 13-year-old lady, girl with the family, that all family ladies had the breast cancer with this gene. So that young lady's mother requested surgery on bilateral breast in the 13-year-old girls. It was quite a publicized, still very argued about that decision. And because even you have this gene, only 15–20% develop the cancer. But obviously the relative risk is much higher. And so earlier sort of surgery or management is certainly useful in certain, but no one knows the future except for God. So there's a continuous argument. This TP53, P10 are sort of a tumor suppressor gene. These are oncogene. So if these suppressor genes become less by some region, then they can develop also hyperplasia, carcinoma, and eventually metastasis. And the overstimulation of all this estrogen, progesterone, growth factor makes a hyperplasia. And as you see, mixed gene was there. Somebody, can you Can you mute somebody? I hear a lot of noises. Okay, there's a still.
I think there is a howling. Would someone close the...
Questions? If you have a question, yeah, put. There's a lot of noise somehow. Dr. Sir, can you take a question? Then I can.
I think it solves, sir. So I think you can proceed.
So it's okay. Retroblastoma genes, and these are all genetic influence this continuous progress, and so we'll. Because of these known things, when somebody has a certain nodule and certainly biopsy will show histological certain cell type grade, but they must have a gene profile to predict certain things. Okay, now, just like prostate cancer, a certain estrogen comes and the receptor stimulating, but through the certain pathways. There's several has kinase usually connected to all this PI3K or AKT. AKT, there's also gene which makes a cellular proliferation, particularly this stimulating also glucose metabolism in cancer. Okay, so these several either hormone, growth factor, and going through pathways, stimulating cellular proliferation and eventually metastasis. So nowadays, breast cancer are classified based on genetic profiles. So you probably know that basal type, luminal type. Luminal type shows estrogen receptor positive and progesterone receptor positive. These generally show better prognosis with the hormonal therapy. But there's a basal type, estrogen receptor negative, progesterone receptor negative, and also oncogene HER2 negative. This called triple negative. It's a very bad cancer, difficult to control, and this kind of cancer spread out fast. So this all the gene profile makes a significant prognostic difference. Okay, now there's some reports show certain unusual, certain genes, and that shows certain influence on breast cancer growth things. So in this case here, X11 reduce estrogen receptor positive breast cancer cells. So maybe this is a somewhat suppressing estrogen receptor function. And this another one also to find. This also reduce some resistant breast cancer, therapy resistant breast cancer. So that's kind of, and certain kinases with this ESR1 gene makes also some tumor proliferation, and the insulin growth factor and the certain red gene also elevated by ESR1 fusion in vitro, in vivo models is all reported. So besides the common ER, HER2, there are several other this kind of genes also recently become known, and so it's, any therapy ends up certain drug resistance. And so a lot of studies show why, because of certain genetic alteration, and in this case, breast cancer, certain ESR1 gene fusion makes some drug resistance. So there are already drugs inhibiting this kind of genes. So here again, this kind of recent report shows mutation in this particular genes that will make a resistant of hormonal therapy in breast cancer. So again, in the classification of breast cancer nowadays, you divide the invasive, non-invasive. And this early stage of ductal adenocarcinoma or lobular. Lobular is about 15 to 20%. It's much less. And this ductal is arising from duct, gland duct. It's a lobule. It's a lobule. So invasive ductal, invasive lobular. And the if histologically shows some lymphovascular invasion and microcalcification and the hormone receptor and HER2. These are the all prognostic sort of factors. So routinely nowadays, molecular pathologists report all these kind of things for the management of breast cancer. But just like any other cancer, cancers are continuously evolving biologically. So this kind of static information cannot completely predict whole sort of life, survival, etc., because of a changing pattern. So theoretically, we have to try to have a tissue biopsy as many as possible, ideally. So that's practically impossible. So there have been a lot of trials of so-called radio genomic studies. What that is, genomic gene profile overlaid imagings. And so from imaging, we can possibly predict gene profile, predict a gene profile. So that's quite a new, interesting. If that works well, that's great, because it avoids frequent biopsy, tissue assay. And pathologists look at a just static picture in certain limited area. But imaging whole body, particular region at least, can show anatomical morphological abnormality. If that abnormality has a certain genetic association, we can tell whether certain genes are upregulated or suppressed, etc. So that's the ongoing, and that's the future of personalized management of cancer. And here you can see histologically all this ductal, lobular, and then certain papillary. These are all different here. And so generally, okay, this early sort of Dr. or lobular carcinoma in-situ, low-grade luminal type has a good prognosis. This is a good prognosis. And then, but this kind of classical pattern become pleomorphic. It changes biologically. Then it's not good cancer. So high grade from the beginning is HER2 oncogene positive. Usually give a bad, that's make a Paget type cancer. So this will expect metastasis and resistance to the hormonal therapy. And so, yeah, there are histologically other types, tubular, medullary, mucinous, micropapillary, whatever. The slide is very blurring here with some distortion. I don't know what's happening. On my slides, everything was clear. But anyway, these are very 1-2% things. So occasionally you have a very unusual type, but treatment in general are same. So we are clinically, basically 70-80% are ductal adenocarcinoma, and the other 10-20% is a lobular, okay? And the lobular is a little bit better than the ductal adenocarcinoma. But the gene profile is most important. There are certain known risk factors of breast and breast cancer prognosis. White compared to black, other things, has a slightly higher risk. And the older patients certainly has some higher, because the older people has some other underlying diseases, including inflammation. As you know, inflammation triggering the cancer prognosis processes. And certainly in the family history, if they inherit certain this BRCA mutation, that's a really bad risk. And so if any patients, mother, sister, daughter, these things are, the risk is 4-6 times. And then also history of endometrial cancer, because these are also similar estrogen-related cancer. And certain types of like a fibrocystic benign disease, but proliferative form, this can also continue to make a carcinoma. In clinics, we usually check with the menstrual history. Early, nowadays, young girls, 10, this age 12, but now most young girls have menstruation around 10, age of 10, and also late menopause. With a lot of estrogen stimulus, and they have a menopause even after 55. So, but if they have a pregnant baby, breastfeeding, this is not happening. So now again, in other factors, the size obviously bigger is worse, okay? And recurrence is more frequent in bigger. Okay, and in as I mentioned, hormone receptor negative is a bad, worse prognosis. And DNA cytometry, usually we check this. Histologic grade, obviously, high grade, poorly differentiated, that's a bad. And then tumor labeling in this. Also cell cycle, S phase usually, because cellular proliferation. And certainly lymphatic or vascular invasion is a bad prognosis. Cathepsin, immune, that's also high, is bad. Again, HER2 oncogene, that's a usual. Certain EGFR is also bad prognosis. Now, most commonly, breast cancer occurs upper outer quadrant. That's why it goes to axillary lymphatic chain. Now, around nipple is rare here. And usually, we'll call it Paget disease of breast starting in nipple. But that's usually adenocarcinoma. It goes deeply. So it's a bad prognosis. Now, upper inner quadrant here, this gave worse prognosis. It goes to internal mammary channel. Internal mammary channel is about here. So it goes here. And the inner lower is not common. But the inner side, you have to always check internal mammary lymph node. This side usually go axillary, level 1 first, level 2, 3. I suppose we have a 10-minute past, right?
Yes, sir.
Okay.
You can.
All right. To evaluate breast cancer or mass, as you know, generally we start with the diagnostic mammogram as a screen, and then if there is a clear-cut sort of finding, then either biopsy or surgery. But many times mammogram shows something, but it's not clear-cut. Then we go ahead ultrasound, or in the United States, MRI. Ultrasound is a cheaper, easier, and high resolution, but it's quite a subjective. So depending on experience, a lot of things, the outcome is quite a variable. And also many referring physicians are difficult to recognize by themselves. So breast MRI more expensive, but standardized technique. If there is some metastasis suspected, then we are using PET scan using FDG. But FDG we know is non-specific, particularly with certain inflammatory reaction lesions. So there was trying to make a breast-specific gamma imaging, but it's not been successful. And for staging purpose, we must check a central lymph node. As you know, nuclear or blue dye combination makes a certain central lymph node based on certain biological consensus that tumor spread out sequentially from the first chain and the next chain, but about 10% is skipping, so it's not all reliable. Certainly, other imagings maybe help. Certainly, if there's a suspect of bony metastasis, nuclear bone scan is still more sensitive. Nowadays, PET with higher resolution, sodium fluoride, but it's MDP or phosphate and fluoride. The mechanism is different. So some lesions show on this one, some lesions show on PET things. So sometimes they end up having both studies, quite expensive, but both studies. So that's why a evaluation of a therapeutic response we end up having all kind of imagings, but I like to re-emphasize about labeled drugs, tamoxifen or a certain chemo agent can be easily labeled by our isotope. Then if the labeled drug will be more specifically identify the recurrent remaining cancers. So serial study obviously show response of therapy, etc. And then F18 labeled estradiol should be more emphasized and should be utilized in the clinic in near future. Estradiol is certainly, as I mentioned earlier, is a component of breast cancer in most cases. But labeled drug seems more useful in clinical purpose. Now, okay, mammogram show typical classical cancerous mass. Mass is greater than 3 centimeters. It's called mass. Other than small is a nodule. And speculation is typical for malignant because the tumor is trying to proliferate in all directions. So it's like rounded, but the margins are not smooth. That can be in the lung, any cancer show like this. The ultrasound show, it's a normal echo, this quite dark, but the replacing tissue, so the rebound echoes are less. So here looks dark, but here, okay. MRI with contrast, that's enhancement. Even without T2 images, generally show high signal intensity. T1 is usually low or intermediate, but contrast agent will make a brighten because of neovascularity, particularly in periphery. So here, remember, lots of fat. This is a T1, so it's a fat. So just ductile or lines here, and there's a little bit speculated. And the fat suppressed T1 or fat suppressed T2 show brightness. And also with the contrast, it enhanced these vessels here. And ill-defined this mass on ultrasound. It's normal tissue echoes, but it's no echo, but margin is ill-defined. Now, here on, okay, here little bump, but margins are not clear cut. It's not easy, okay. And then digital images, that's usually show some fat separation, much clear image, but still difficult. And 3D tomosynthesis certainly show the best, better, but still not clear cut here. That's why ultrasound, MRI, if there's any question. If there's a microcalcification, then that's it. Microcalcification is a hallmark. Micro. So some old studies show comparison. Certainly, tomo was the best, but it's similar to MRI. But tomo is much cheaper than MRI, but it's much better than digital mammogram. So nowadays, most cancer centers use breast tomosynthesis and MRI for biopsy purpose ultrasound, high resolution ultrasound. So these are the finding. Okay. So it's the sort of heterogeneous is a hallmark. Heterogeneity is a hallmark of cancer carcinoma. So this BI-RADS, that's abbreviation of a radiological sort of mammogram or MRI. The category 1 through 6. So 1 is nothing, no abnormality. And then 6 is a known cancer, or 5 is probable. We use, because no one guarantees, so problem is greater of 95%. And this 5 require biopsy. And 4 is possible, suspicious. And that's a recommend, but not mandatory. And then 3 is probable. And then 2 benign and 1 is normal. So invasive versus fibroadenoma, which is a common, that's also benign lesion. So instead of round or irregular, this ovoid, elliptic. The margins are smooth instead of speculated. Okay, the microlobule or microcalcification, punctate calcification is common, but macrocalcification is benign, little bigger than, sound like a punctate. And so that's a hallmark. And some suggest the orientation taller than wide for invasive and wider than tall, but these are, particularly in ultrasound, they squeeze the breast, so this is difficult to convince. Hypoechoic, that's a usual, but some cases isoechoic. But if there's a hypoechoic, that's definitely benign, okay? And the here doesn't show contrast in it. Okay, here, so it's a well-defined, it's a nodule on mammogram, and then a shape around the margin is fairly well outlined. And in hypoechoic lesion, so margin well-defined, and not much shadow. If there's a calcification, you expect a shadow, So it's a benign fibroadenoma. But some cancers also look like this. So if you see here, then usually biopsy regardless of thing. But if a patient reluctant to have a biopsy, no symptom signs, then short sort of a repeat study. Short means in 3 months repeat study. That's a usual practice. Ultrasound, some kind of the echogenic spots here is a calcification. And the ill-defined hypoechoic mass here. So this is the carcinoma usually. Calcification and ill-defined speculated mass, that's a finding. Now here, you can see very well-defined nodule. It's a small nodule, small nodule. It looks like a fibroadenoma, but it turned out to be ductal carcinoma. Probably a hyperplasia become adenoma. Microadenoma become macroadenoma, and then carcinoma in-situ. So this is a shape, could be this or could be adenoma. So that's why we always have a biopsy regardless the shape. We can suspect, but you cannot guarantee. But now we also check a CA 15-3 or 27-29. That's a marker of breast cancer. Breast cancer, any cancer secret a lot of certain protein, peptide, enzyme, hormone things, and then carbohydrate antigen, CD, and then this one, CA. The CD is called differentiation, certain numbers they put. But CA is a carbohydrate antigen, tumor produce the antigen. This is 15-3 or 27-9. So if we check the blood test, show that's outside the normal range, that's require biopsy, definitely. Now this another is a large, this is a mass and fairly well-defined margin, and internal this density is fairly smooth here. So it's a benign type by appearance. However, this is called cystosarcoma. Sarcoma is a rare, very rare, but it's a bad cancer. So imaging finding is not guaranteed certain histological type. This is another phylloides tumor, which is a benign, well-defined here like an adenoma type. And it's also hypoechoic, oval shape, well-defined. It's benign, most likely. But here, irregular, and some echoes, either calcium things, this is called papillary carcinoma in-situ. This is a variant of ductal adenocarcinoma. It's a rare, as I showed earlier, but shape is not benign. And also you can see post-acoustic shadow here because of this calcium, the shadow. So that's suggesting calcification, and then some not clear-cut margin, that's malignancy. Now here, as I said earlier, skin thickening is like this, but it's very thick around the nipple. Nipple is retracted. That's another sign of cancer. If cancer here is pulled inside. And then this thickening could be mastitis, inflammation, or infiltration of cancer, both. And the Paget is rare, usually lady over 50, usually nipple problem, so nipple cancer. But this duct is all contiguous. So even you don't see nodules here in the duct, this requires surgery, they investigate all the way. So you have to treat Paget disease as a ductal adenocarcinoma, but it's starting from nipple. So the imaging finding mostly just the nipple retraction and skin thickening around the nipple. Yeah. So invasive cancer, sometimes you can see very red, enlarged breast, this whole inflammatory. So this inflammatory breast cancer is a separate sort of a category because this has a different prognosis, generally very bad prognosis. It's like just the inflammation, and the so it's patient complain pain, and then nipple retraction, flattening or things. So these are the classical finding of invasive, but this is inflammatory breast cancer. Very aggressive cancer. and only 2 to 5%. So it's a primary, secondary. Primary, previously normal breast developing this, but the secondary is certain after certain biopsy, surgery, previous certain disease area developing cancer. So the problem is that only even though inside is a whole breast is inflamed, the lump it was palpated only in 30%. So that's why most unexperienced people assume this is just mastitis, particularly after delivery, baby, and breast is engorged, huge, and then they often just like this. And so there's no nodularity thing. Whole breast is like inflamed. So mammogram missed the diagnosis of inflammatory breast cancer, and but the lymph node, because of fast metastasis, the lymph node is palpated, usually axillary and also supraclavicular. And again, this inflammatory breast cancer can be all this receptor positive, but HER2 generally usually positive. So the HER2 is much of almost double compared to non-inflammatory breast cancer, 40% at least, and the triple negative. Triple is ER, PR, HER2 negative is 30% instead of 15%. But they also have ER, PR positive in half. So this can be treated with the hormone therapy, but the other all chemo from the beginning, because the whole breast is diseased. So here, just a little thickening of the skin, that's about it. No nodularity, no nodularity. The skin just thickened, but the breast itself doesn't show any nodule. Okay, now this is why they go to metastasis fast. They recently proposed this gene, CXCR4, that's all influence of inflammation, and inflammation, this triggered progression, so metastasis. So in addition to STF1 gene and this CXCR12 gene also contributing to metastasis, bone, liver, lung, lymph node. As I said many times, every tumor goes to lung eventually. If they are not controlled, they go to the liver, bone, every other place. So inflammation is a remodeling. Inflammation, certainly angiogenesis, lymphangiogenesis, all together make this kind of continuous progression. So this is called chemokines. These are chemokines that makes all this metastasis. So in breast cancer, as I said again, usually morphological study by ultrasound, biopsy things, and then short follow-up or treatment. So digital mammogram is now standard, and the FDG PET is mostly helpful for metastasis, but primary is not. Lobular type, slow growing, FDG doesn't show enough uptake. But aggressive tumor, sarcoma, or ductal, invasive, it shows. Sesame FDG show similar finding in small tumor. Sesame is based on cellular membrane potential difference. FDG, glucose is related to glucose transporter, hexokinase, pH in the tumor, and certain genes. MRI has the highest sensitivity but more expensive. Now, with this kind of staging, sort of less than 2 centimeter is T1. Greater than 2 to 5 centimeter, T2. Greater than 3 centimeter, T3 by size. Certainly, chest wall environment, skin environment, and distant organ environment, the bone, things, they're all stage 4. Inflammatory carcinoma is a stage 4. But this is a special category. But you should treat this patient as a sort of a stage 4 cancer. Survival, you can see dramatic difference. Just less than 2, stage 1, 95%. Mostly hormonal cancers. But stage 4 usually very invasive or inflammatory cancer, survivor, 5-year survivor, that's 20%. But most cases, clinical cases is in this category nowadays. Stage 2, that's less than 5 centimeter, and lymph node negative, or less than 2 lymph nodes. These are most common in clinical things. Okay. Here you can see sort of a microcalcification, just a tiny sand-like and irregular, some certain mass you cannot even outline. But microcalcification, that's key features. And you can see calcification also all diffuse here, whole breast cancer. But here sometimes calcification is clumped together, but enhanced mass, this is contrast enhanced T1, fast suppressed, irregular, that's a hallmark, irregular. In enhancement, all cancers are enhanced. Now, here you see some enhanced, but it's difficult to outline. It's a diffuse cancer. Here, okay, it's almost linear things. There's another pattern, but margin is not clear. So enhanced after contrasting, gadolinium contrast enhanced. So generally cancers take a contrast agent and hold it. But normal usually goes up and washed out because there's no lymphatic vascular channels are wide open. But in cancers, that's a usual pattern. But there's some variation, so depending on how much the surrounding microenvironmental vascular lymphatics are obstructed. So this up and slowly down, that's a most common thing. But some goes up and just hold it. or continuous up, 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 that's all malignant. So 3 pattern. But this lobular cancer is going up slowly, downhill slowly. So some early doctor also show similar pattern. So just looking this one is not easy, but generally just hold the same thing, FTG, go there and utilize continuously. That's a common pattern for malignant cancer. So here, lobulated, similar to, so radiographically, I think you cannot separate, you cannot make a histological separation. So they all look like ill-defined enhanced mass. And some unusual shape, enhanced mass. That's a lobular, sometimes very small nodule, almost like an intramammary lymph node. And the small echo, hypoechoing nodule. But this is the margin is fairly well outlined. That's a lobular instead of ductile. So this one has a better prognosis, but contrast goes slowly and retain. That's a cancer. So speculated margin, particularly rim enhancement, that's because central necrosis usually in bad cancer. So only rim enhancement. And tiny solitary lesion, microcalcification, and then they show the curve, time active curve after contrast injection, slowly or continuous up and retained. Okay, MR missed a certain cancer, certainly artifact too small, 1-2 millimeter, although MR ultrasound CT has a 1 millimeter resolution. But in fact, if you see less than 1 centimeter lesion, still difficult. It's because benign, malignant, the characterization is limited by the size. So those are small cancer can be missed, and certainly artifact, surgical artifact, and but diffuse infiltrating, like inflammatory breast cancer. Diffuseness, you cannot see a nodule, you may miss that kind of. Okay, now the invasive breast cancer often metastases to the axillary lymph node, but supraclavicular lymph node. And then you can see this is a nerve we call brachial plexus. It comes from C5 down to T1. So initially the two together makes a trunk, upper, middle, lower trunk here. And then this mixed, this cord, lateral, posterior, medial by location. So if a tumor extrinsically compressed, you have a terrible pain or numbness or that kind of thing. This scalene muscle, anterior scalene muscle, middle scalene muscle, scalene. So it's a lower neck, it's a lot of vessels, it's empty here, and these muscles in here. And if you see line here, that's this kind of trunk or cord here. So if there's an enhancement along this nerve, then you can fairly say there's an infiltration by tumor or, yeah. So that's brachial plexus, sort of a nerve sort of involvement. That's a very common problem in clinical practice, brachial plexus. So here, this brachial plexus is sort of a cord or trunk, and tumor enhancement is surrounded, squeezing nerve and cause nerve compression syndrome. This patient has a lung metastasis already. That's a lung. So in nuclear medicine, we have a multiple agent to detect or evaluating breast cancer and prostate is all, and neuroendocrine, etc. So estrogen, estradiol labeled with F18. Okay, this testosterone labeled one. This is all hormonal. And then certain antibody against a certain HER2. This is drug, trastuzumab for the HER2 suppression. So labeled with the zirconium 89. As you know, neuroendocrine tumor. In breast cancer, any cancer can have a small cell type. That's called neuroendocrine type. And then dotatate now is a choice. The gallium or F18 dotatate detect, and if we use lutetium 177 dotatate, we can even treat metastasis. And the estradiol and certain testosterone hormone, that's the more specific. But this drug, the labeled drug, is useful to evaluate the response of therapy. So here, okay, sestamibie, okay, breast here, and certainly it looks like a large mass, margin irregular. I don't know whether it's a microcalcification or not. But with this one, certainly we suspect cancer, but it's a ductal, lobular, you can tell. You have to biopsy. And the FTG, maybe show very nicely. Not only this, also several, maybe satellite, whole breast. Now, why maybe go the cellular membrane, this potential is different. Maybe in and out things, P-glycoprotein influence here. So this kind of things also influenced by BCL2 oncogene gene. So it's a cellular membrane potential that it goes into the nucleus, and this in and out is also influenced by P-glycoprotein. So it's a lot of sort of BCL many, but bad box, other this oncogenes influence maybe staying inside the mitochondria here, mitochondria. So why they go to bone rank this the gene influence stimulating osteoclast, but other like IL-11, parathyroid hormone, growth factor, etc., all postulated. So a certain cytokine and even VGF is all contributing. So osteoclast versus osteoblast normally should be balanced, but in this kind of cancer patient, the balance may be broken, and depending on which one is predominant, you may have some healing appearance, you may have a destruction on X-rays or imaging in general. So here, okay, a large focal rounded, another small, after treatment is gone, okay? So it's this one is a MIBI, sestamibie study. And MR large enhanced mass has gone. FDG, marked uptake almost gone, a little bit left, gone. Yeah, but if there's inflammation, you do the same thing. Now here, the fluoride, sodium fluoride, directly exchange of hydroxy, the -1 anion in the cortex. FDG uptake is different. So when you compare these two, it shows here, shows better in the bone, obviously. But some, maybe this axillary node, you barely see it. But here's the intense all things after treatment, only two, whatever body show a little bit uptake here. But fluoride doesn't show much. Maybe here some is so dark. What it means is that this metastasis is in the bone marrow, but this one is in the cortex. So this will show only cortical abnormality, not the bone marrow. But FTG show abnormality in the bone marrow of the bone marrow. So it's two different things. So here, fairly well marginated mass or pulse. And here also. And hypoechoic around there, some echoes here, but fairly well outlined. And then here, the FTG, yeah, you can see very intense uptake here. The gluteus minimus lateral is a level 1. Medial level 3, interbacterial middle here, or retrobacterial, that's a level 3. And so here, FTG again, some ill-defined mass, here intense. And in the liver, you can see here. And so here, breast, that's all. Again, axillary and the breast cancer first metastasis to the anterior upper rib. And after they go to the lung first. So usually lymph node first, and then after it goes to thoracic duct, and then go to the lung, and then go to the sternum or upper ribs. That's the usual. So here also a lesion here in the more likely. It's this is a kidney, but this is by actually here we can see. Here this thymidine. Thymidine is directly incorporated in the protein synthesis or DNA synthesis. DNA. The thymidine, certain cytosine or guanine, or what's that? Guanine, cytosine, thymidine, and the cytosine. Those are 4 sort of amino acid things, and so this will be more maybe reliable, specific for cancer, maybe the growth or metastasis. However, unlike FTG, the uptake in the tumor is much relatively less. That's why we don't use it. The FTG uptake is still more in any tumor, better than other agents. But FTG is non-specific, this is reflecting more sort of DNA synthesis.
Giấy sách người ta mới nhận chứ.
Yeah.
Làm xong rồi.
Okay, here, okay, routine bone scan. Okay, you see the lesion here, and this may be greater trochanter by degenerative, or trauma here. Here may be lesion here, and this humeral head could be metastasis, could be, if this is a great tubercle, that's a stress reaction from the attached muscle, but could be metastasis. So internal external rotation is important, but there is a metastasis in the left frontal scar, maybe here. But on this PSMA, you see numerous metastases in the lymph node and the bone, all that kind of thing. So it means this tumor, breast cancer, has a certain PSMA. So PSMA is not specific for prostate cancer. Many other cancers has a prostate membrane antigens. Okay. And then same thing, this is a FACBC, it's commercially called Axmin. This is a synthetic leucine. So if we use amino acid, it goes to a protein synthesis, but this synthetic leucine goes to tumor by amino acid transporter. But just like FTG, no more metabolic process. So we are seeing phosphorylated leucine, that's it. So it shows very nicely any tumor, particularly prostate cancer and also breast cancer as well. Breast. So PSMA goes to this, we are injecting antibody. So PSMA antibody goes to PSMA antigen, but about 15% prostate cancer doesn't produce PSMA. And breast cancer, probably a lot more. So in that case, happen to have a breast cancer secreting PSMA. But this leucine, any tumor with cellular proliferation will show like this. So now DOPA. So breast cancer also has quite a dopamine substance, dopamine. Dopamine is produced by some gut, liver, all things. And many sort of serotonin, this a neurotransmitter also produced in the gut. And this dopamine has been used primarily for brain tumor. It doesn't accumulate in the normal. It goes to a certain pathology with a dopamine receptor. So breast cancer also shows, very speculated on MRI, show a good, nice uptake here. And much less background. And this is a anti-angiogenesis like Avastin, this Galacto, RGD, and goes to tumor based on VEGF receptor, vascular endothelial growth factor. So it goes here. So the lung metastasis axillary show. And this progesterone labeled F18 showed also here. But estrogen is a lot more. Again, progesterone is secreted in lutein phase instead of follicular phase. But it shows uptake. So it's a lot of hormones. And this is estradiol, very nice uptake. So since breast cancer component is most likely estrogen accumulation, estradiol, most common out of 3 types, it shows. So this will be much more specific for breast cancer. And so some studies report like 2 cases. Here, FTG show lots of lesions fine. In this case, only 2 lesions. Okay, but yeah, estrogen receptor study show in this case, it's a lots of lesion. And then after they give a treatment, it's gone. This is a hormonal treatment, but even hormonal treatment, some lesions are not responding. Like a water study in earlier days or related to vascularity show, but that's not practical. Misonidazole hypoxia, any aggressive tumor has a hypoxic cell. Hypoxic cells are resistant to radiation therapy as well as chemotherapy. So recognizing hypoxic, once you see enough hypoxic cells, you must give more drugs or more sort of more aggressive radiation therapy. Now let me talk about estradiol and a lot of publications, earlier publication, all the things. And then again, similar, FTG show lots of lesion, but estradiol show a little bit. So in this case, hormone therapy may not working. There's not much estrogen receptor there. These are all just glucose metabolic process. So the accuracy around all the 80% things, so not 100% in anything. Now, important is evaluation of hormone therapy. You can see FTG as well as estradiol, very intense uptake. And the here maybe this looks like a Mammogram sternum, and then this is after treatment or some, but there's a marked response, good response by intensity, almost gone. But in this case, FTG intense metabolic activation, but no receptor here. So even you have a therapy, hormone therapy, no response. So guiding hormonal or chemo, this is a good way, more specifically. So same thing, there's estradiol uptake, predict the response by hormone therapy. So after menopause, we use aromatase inhibitor. Before menopause, tamoxifen. And then by using this estradiol imaging, we can separate the responder, non-responder. So here, aromatase inhibitor, HER2 positive, show lots of good response. Negative, so you can see difference. So HER2 negative is a good, then means it's an estrogen receptor is not there. But HER2 positive, bad cancer, estrogen receptor there. So this case require chemotherapy. Okay, so again, tamoxifen, there's a hormone response gone. And it's another new hormone therapy, not much response. Okay, the meningioma usually in convexity or this cribriform plate area. So here, enhanced is right around this nasopharyngeal space, and this petrous ridge, that's a bone, so probably meningioma. start from this petrous-rich area. And then breast cancer metastasis, appearance is very similar. So radiographically or MR cannot separate metastasis versus meningioma. Although some bigger ones show a lot more. This meningioma benign, so they keep certain benign features like margin or internal characteristics. But cancers generally growing, so margins are irregular and central necrosis. But at some point, it look like. And because of soft tissue abnormality of breast cancer, PET, MRI, hybrid has been tested and showed a certain expected usefulness. MRI show anatomical feature, PET show certain functional, okay? And in certain, this one is a bone, just a bone scan. And so if a CA15 industry is rising after treatment, and then they have to survey bone by using its PET agent or some PET MRI, whole body using FDG. Now, oops. Again, the PET MRI is still expensive, but the good thing is if we use PET, we can talk about glucose, cellular metabolism, cellular proliferation, angiogenic activity, but expensive, and then it's a little blurring, and then still not yet standardized protocols. And the stage 4 sort of disease, we manage based on first, estrogen receptor present or not. So yes, hormone therapy, no chemotherapy. And if hormone therapy respond and continue, no response, and other targeted therapy, or recently immune therapy, that's a management. So this receptor, estrogen receptor, there are so-called SERM, that's a selective estrogen receptor modulator. So tamoxifen, letrozole are common. This tamoxifen premenopausal, letrozole postmenopausal. And those are the things. But after 1 year, 2 years, these become resistant. And so, but now there are many new hormone therapy. And certainly genomic studies show why certain resistance develop. And a certain mutant protein have been recognized here, all things. And so, and then there are drugs to modulate this kind of resistance. So in the management, surgery, if possible in early, but usually now there's lumpectomy to avoid the lymphedema. So central lymph node dissection, etc. So surgery. And then local therapy, still local therapy for individuals. So if the tissue show ill-defined margin, and then they radiate it. And then certainly certain aggressive tumor, usually neoadjuvant or adjuvant chemotherapy using FAC, 5-FU adriamycin cytoxan. And then if ER positive, estrogen receptor modulation. And then there's a new drugs. And so if there's tamoxifen or letrozole become resistant, and then they change. And then targeted specific antibody against the oncogene or angiogenesis. And then certainly in bone metastasis, bisphosphonate has been helpful to avoid the bone reabsorption. However, bisphosphonate make a side effect of necrosis in the mandible. So that's the problem. And yeah, so this third, and then aromatase inhibitor is a lot of anastrozole, exemestane, and some raloxifene, chromifene, all this fulvestrant. These are all new sort of either oral injection or thing to hit the estrogen receptor. So that's why people with the breast cancer are living longer with all these new medications. And then another newest antagonist of estrogen receptor is named the AGD9833. The company usually start with all kind of this number, and later they put the new trade name. But it's working in particularly CDK, this immune CD4 or CD8, that's an immune T cell component. So it's a lot of adjuvant, and beside this FAC, and there's Taxol, and then certain combination, usually combination with the trastuzumab, because this to hit the HER2 oncogene. So that's usually common. And patient-derived certain data, PDX, prior to doc. This is Taxol treatment shows a significant decrease of tumor heterogeneity. Tumors are all heterogeneous, but after certain treatment, the biopsy, they show less heterogeneous sometimes, but sometimes the other way around. And so it's very variable. That's the difficulty to control cancer. So in this case, again, some data show decreased cellular proliferation and cell death increased by the treatment. The triple negative breast cancer is a bad cancer, very high rate metastatic recurrence. So paclitaxel, doxorubicin are the first, doxorubicin, paclitaxel. But the complication with all numb fingers and the skin sort of all rough skin and peeled skin, those are the common complaint from patient. And the Taxol stabilized microtubule, that's the induced mitotic arrest, that's the mechanism. So, but it blocked eventually DNA replication. And now we don't have much time. I have to move quickly. Okay, in half an hour, when the ladies complain pain around the pelvis, you have to think of a lot of diseases. Certainly, physiologically, ovulation, menstruation, they do have pain. Pelvic inflammatory disease is very common, but other cyst, fibro, endometriosis, that's a common in Korea, Asians, and certain benign fibroid, but malignant. And in elderly, prolapse of uterus or bladder, cystitis, calculus, and also a small bowel or large intestine, ulcerative colitis, Crohn's disease, and in the United States, diverticulitis, and also irritable bowel syndrome, certain stressed people, and then cancer. And then even lower lumbar disc, other sacral stenosis, spondylolisthesis all give pain in the pelvis. So differential diagnosis is not easy and require a lot of imaging study. The MRI in the United States is most popular, but if there's a mass suspicious palpated, the ultrasound, or the high resolution ultrasound usually. And then if we are sure about the cancer, the opacity is certainly. Yeah. Now, ulcerative colitis or Crohn's disease, we can use the Indian 111 labeled the white blood cells, because these conditions leak the white cell. So imaging studies show such a persistent activity leaking in the lumen. Normally, Indian locus should not show any bowel activity, but they show. So that kind of things. But this disc or this MR can show easily. So on this T1 lateral, you can see introverted uterus, and it has a large mass here. Okay, the uterus itself has an endometrial cavity here. There's some secretion. That's this is a T2 weighted imaging. So secretion usually show high signal. And then in the muscle myometrium here is like a dark. Inner is like a band, dark band, fibrous tissue here. And on the serous tissue also dark here. But this is a mass here. And the disc here, T2, the nuclear pulposus has a water normally, it's a water all dried up. So this is a degenerative disc. This is L4, 5, L5, S1, they're all degenerative. But the disc is not collapsed. There is no spondylolisthesis. And the spinal canal here, these are nerve coming, cauda equina, L1, spinal cord count L1, and then branches here. And then if this space is narrowed on axial, and that's a spinal stenosis. It looks like a stenotic. So this uterine cancer is still quite a common GYN cancer in every country, particularly Korea and Asian. Okay, as you might know, human papillary virus is a major contributing factor. So nowadays, we advise many young girls to receive a vaccine, but there are 40 subtypes. Current vaccine hit only 4 types. So if the girl is lucky, then it's helpful, but many others are wasting. The one injection costs $1,000 in the United States, but they have to receive at least twice. So that's why there's a lot of argument about vaccine, because this virus are changing shape and make a subtype. So that's a dilemma. 90% are squamous cell cancer. Squamous cancer generally has a lots of glucose uptake, good glucose uptake. The glucose metabolism is very active. And also it's generally radiosensitive tumor, so radiation is there. So this is metastasis usually start to parametrial. So this is important stage, guiding stage 2, 3, 2. So that makes a difference in therapy. I will tell you more. So parametrial, external iliac, called obstructor, and presacral lymph node. So prognosis related to staging, tumor volume, metastasis. So 1/3 all is local recurrence. That's the problem. So that's why after hysterectomy, the radiation, that's the usual. And then chemo radiation is usually locally advanced, but distant metastasis are all chemotherapy. So it's a stage, yeah, the 1A, 1B, 2A, these are all surgical. But after 2B, that's a parametric environment. And then for the progress, that's all chemo, radiochemotherapy, with without surgery. So here, just this is a vaginal. Vault here is a uterus here, this is cervix. And then 1B is all by size, 4 centimeter. 2A is right here, but still limited the cervix and then here. But if they involve parametria, goes here, and then 2B. And then certainly is down to upper vagina, or go to some attach the pelvic wall, or go inside here, that's or stage 3. And for the distant bone environment, the bladder, rectum, all the stage 4. So here, ultrasound, it's a little bit hypoechoic, but it's difficult to, clearly say. And this the transaxial image of MR on T2 bladder has a high signal, and this is a uterine cervix, so as a sort of a ring, and has this fibrous margin. And this is called parametrium. So if tumor goes here, that stage 2B, attach here, pelvic wall things, that's what we are looking for. The sagittal, you can see cervix here. This endometrial cavity, myometrium, so you can see fibrous band around outline here, and serosa also here. And then normally the uterine cervical lips show some fibrosis. And here's a tumor and down extending into here, it's the whole thing here. And then here, this cervix, little here, and then it's a lymph node. This obturator, this looks like obturator or hypogastric, little this little there's a vein here. And here you can see a bumpy uterine cervix. And then here, now here's a tumor here. And then it goes a little bit extend here or here. So if they penetrate the margin, that's a 2B, parametrium, or posteriorly 2B. So here, okay, this ring, and that's the margin here. It's not clear here. And here, the bladder involved here. Sometimes the tumor, this rectum, sigmoid, this wall, a budding, attached here, maybe invading, that's already 4. And so MRI is best to staging. And here often ureter is pushed by lymph node or tumor cell, make a hydroureter or hydronephrosis. So hydronephrosis is a significant finding for cervical cancer. Certainly, the coronary renal failure can occur with long-standing sort of non-obstructive dilatation makes renal dysfunction. You can see a lot of lymph node, retroperitoneal lymph node. Okay, so mass here, this is a bone, sacrum, coccyx, so bone already pre-sacral from recurrent cancer, lymph node environment, bone environment. Okay, so here this L5 on T, probably contrast T1, enhanced. Now on this PET MRI, we can see metabolically active tumor, and then this is bladder, but it's some fluid, cul-de-sac space. That's a space between rectum and the this uterus. Normally there's a fluid. It's a lot more than this. Abnormally, a lot more. Yeah, and so the lymph node metastasis and the tumor here metastasis. So PET MRI can show, and you can see multiple lymph nodes here. The pelvic retroperitoneal. And now endometrial cancer, which is, see, cervical cancer has been less because of early diagnosis and therapy. As I mentioned earlier, in the United States, they remove all uterus. So the incidence of cervical cancer very low in the United States. In Korea, there's still some uterine cervical cancer, but much less, is less with the pap smear, early diagnosis, and hysterectomy. But this endometrial cancer, which is more related to estrogen, increasing worldwide. So usually bleeding, and the diagnosis is stage 1 because of early bleeding. Mostly adenocarcinoma, fortunately well differentiated. So myometrial depth is a major prognostic factor. So surgery is certainly removable, and the lymph node metastasis or some therapy. Now, again, a lot of proliferation factors, like all genes influence, cell cycle and genes, a lot of genes, and then ER/PR receptor, growth factor together, going through the pathway with a lot of genes makes the things. So that's a problem. Differentiation, same thing. This kind of hormonal excessive hormone goes, and then with the genes and cells proliferating. So microsatellite instability, that's about 30%. Microsatellite instability. So that's mutational alteration. And this called MLH1, MS2, H2, those mismatch in DNA replication. So these things happen in gastric and colon cancer also. So sometimes you can have both, or 3, gastric cancer, endometrial cancer, colon cancer, with the same microsatellite instability due to these genes. The DNA repair genes defect. And so there's aging, certainly estrogen, that's earlier period, delayed menopause, and just like breast cancer, infertility, so never pregnant, and some obesity also contributing factor. Ovarian, same, aging, but also like a breast cancer, BRCA 1, 2, similar. So this is all estrogen related, endometrial ovarian. And so, okay, on imaging, the endometrial just a thickening in the beginning. and some nodular or invasion. So MR is the best to show earlier staging and show about PET CT also shows similar sensitivity things, but MR is the choice for staging system. And the marker, serum marker, we use all different things, but the positive rate is variable. So combining 2 and 3 is a little bit better, but this marker, same marker, rising is so significant, but up and down is not. And you can see initially starting wall, little bit myometrium, a little bit further. The thickness of involving myometrium makes the stage 1A, B, C, and then down in the cervix, you know, that's 2, and then even further here, you can see once you have a vagina, stage 3. And then lymph node, all these things, the pelvic lymph node, the lower retroperitoneal, all the things. So here, the degenerative disc with some bulging disc and then collapse, some disc is, space is narrow. Now here, endometrial cavity is a little bit widened and there's some kind of nodule or mass, but this endometrial wall is very thickened. Here you can see thickened or endometrial cavity has a, but this could be blood clot or a tumor, you can tell. So on the, you see here is a lot of bumpy here. Normally you have a thin sort of a slit, but there's a lot of mass here, all irregular, and mass. And here even further, mass, so all mass. Yeah. Now, important thing is a very early hyperplasia become adenoma and cancer. In the hyperplasia, that's a wall become a little bit thickened. That time, okay, estradiol show markedly increased uptake. That time FDG doesn't show increased uptake. Pathologists cannot separate hyperplasia or very early cancer. The cells are, they call bizarre, not normal, but they cannot tell. So with this estradiol, hyperplastic endometrium is a very easy way to separate early developing cancer. MR is supposed to show just a little thickening, but not easy. And obviously cancer, when the cancer develops, FDG show no question. But estradiol shows some, but much less. So this is a hormone reflecting hormonal content. So hyperplastic cells has more estrogen. Now, endometrial cavity is very widened. Has a, normally there's a thin slit, is a high signal, but this is a lot of intermediate low signal, is a mass of things widening, and then the wall is thickened, but this. And so the some try to separate clearly using both estradiol and FDG separation. That's a good way, better than pathologist. Now, ovarian cancer, lastly, in ovary, you see follicles. Follicles has two cells, theca cells, granular cells. And there's a corpus luteum here. So this corpus luteum secrete progesterone. And you can see also highlight cells, small highlight cells. And then other germ cells here, germ cells. So ovary produce a lot of different tumors, depending on which cell it is. Germ cell tumor here, or epithelial tumor from this mesothelial inclusion cyst, or tunica albiginosa, or this. So histology. So a lot of history, clear cell, endometrioid. That's and then mucinous serous. So serous, adenocarcinoma of ovary is the most common. That's a high grade, but this originated from fallopian tube. The origin is fallopian tube, although it starts here. And mucinous origin from low intestinal tract, colon, appendix, and stomach. So stomach appendix has a mucinous cancer, but they also have a ovarian cancer here, ovarian cancer. So these cells can come, there's origin from all various, how they come here and starting cancer here, and then they come here also. So it's interesting, but no one knows clearly. So ovarian cancer is a problem because we diagnosed at stage 3. Most patients at the time of diagnosis, stage 3, that means outside ovary. So usually have abdominal pain or fluid, already retroperitoneal, all involvement. And then young age group usually germ cell, but most middle age, old age, or adenocarcinoma, papillary or serous adenocarcinoma, serous more common. And rare hereditary home, that's called Lynch 2 syndrome, just a swelling abdomen. And then the hormone involvement, obviously, as I mentioned. Now, this also, this tumor suppressor gene mutated in 96%. Other genes certainly also involved, but there's a mutation BRCA1 to 20%. But many genes altered in 50%. So TP53 is most common, but many other genes. So if we analyze tissue and show TP53 and BRCA, then we can have inhibition of this and then stimulating this. And then other genes, the rare, but it's all show, and it makes all free survival less. A lot of genes, too many genes. So serous, most common, 20-40%. Next is the endometrioid cancer, endometrioid. And so the third is mucinous, okay. And then has a benign malignant, so imaging look alike, but malignant is more aggressive, so it's a mass is more heterogeneous, that's it. But in the beginning, they all look alike. So clinical problem is a peritoneal walls, it's a tiny thing. So even we have a 1 millimeter resolution CT, MR, we still miss 1/3 of a case of this kind of peritoneal seeding. So that's a dilemma. But it doesn't make any difference because a patient come in with the only abdominal symptom, and that's too late already, or stage 3 or 4. So soon after they diagnose, and we usually have a carboplatin Taxol chemo, and then surgery, but this is limited, so you cannot remove everything. So only debulking surgery, because tumors are obstructing intestine, so debulking surgery. And then chemo. Fortunately, Taxol carboplatin respond in 80%, so very good. So they live at least the initial couple of years without recurrence. But then again, the drug become resistant. And then there are so many new drug. And so they live 20, 30 years with a continuous chemotherapy. So as a CA 1 to 5 is a marker, 1 to 5. Okay, my old friend at Anderson developed this, discovered this one. And so that's what we usually, so imaging, staging, but it doesn't mean anything because already all too late. Usually in this stage, we are diagnosing. So for treatment, and why they go to peritoneal wall? So still a lot of research. So a lot of cells in the microenvironment. You can see a lot of cells are involved, macrophage, immune cells, all T cell, NK, this immune cells. So immune cells, if the tumor comes, some tumors are suppressing immune cells. So we have to boost these cells to fight against. The primary tumor comes in and seeding and makes all these immune cells very weak. And so ascites is a major problem. But same thing, cirrhosis makes ascites and malignant ascites. So just tapping ascites, and then you may induce infection, and then all proteins, nutrient will be losing continuously. The mechanism of ascites is still not easy, but a lot of things involved. Albumin certainly, and then sodium, and aldosterone, and renal function. It's all together. It's very complicated. The nitric oxide, as you know, is a sort of vasodilatation. And so these are all many factors contributing together. And the therapy is certainly cisplatin, and then, but now it's Taxol and then VGF study. So many things are now combining chemo. Okay, so often we do secondary reductive surgery, cytoreductive, whenever there's a. This has been very useful, very fairly specific. So if these are rising, there is some cells proliferating. So usually ultrasound or MRI show all peritoneal things better, but generally just CT is usually choice for staging workup. And then for therapeutic response, often FDG PET has been used because it's aggressive tumor and FDG show uptake. But such a 1-2 millimeter lesion would never show FDG uptake. So that's a limitation. FDG show only greater than mostly 1 centimeter lesion. So here, tiny, just nodular things. All this has lots of genes involved here, biologically, all these things together contributing. So usually like this cystic lesion, but cystic or serous mucinous, the margins are even very small. So it's a benign cystic lesion, it look like the benign become malignant. So any greater than 4 centimeter cystic lesion in the female pelvis should consider malignant. So either a biopsy or a short follow-up to see any changes. Usually tapping and then look at malignant cells in cytology. And then here, okay, ovaries normally you see high signal intensity. It could be follicular in young patients or lutein cyst in after menopause, normal physiological. But if this usually 1 centimeter or less, but if this become bigger, 3 centimeter, you must consider tumor, cancer. And then certainly other findings, nodule, some other things you have to look at on various images. Diffusion-weighted images usually show high signal on diffusion images. That means it's a water macromolecular water restriction. If there's so much cellularity, water cannot move. So it show increase. But there is a ADC mapping. ADC map is a quantitative calculation of these things, and they show opposite, decrease. If the decrease on ADC increases, that's usually a tumor or cancer. So here, germ cell tumor is a usually huge cystic mass, and that's in young patients, that's a teratoma or this kind of germ cell tumor. And the liver already metastasis, a very heterogeneity. This germ cell. The germ cell has teratoma has a lot of sort of calcification, or sometimes tooth, that kind of things makes a very low signal on T2. And then again, sort of a bumpy, you can see some extrinsic compression or invasion of the sigmoid wall here by mass here. So all the ascites, that's and then if you also look at a margin, so this is peritoneal seeding, this fluid here aside the peritoneal wall here. It's all nodular here. So all look at it here in anterior margin here. And then here, it's any fluid here is a loculated fluid, but it has a cancer cell. It is all nodular, but it's a very heterogeneous. This is a cancer, but there's a fluid. So this also cancer things. This is a germ cell tumor. So this peritoneal wall is usually here. Any nodular or enhanced, and tiny little bitty small things, tiny things. So on this FD, you can see so many nodular uptake here, and this obstruction distal ureter makes a hydroureter hydronephrosis. That's an important finding. You can see peritoneal seeding around the perihepatic peritoneal seeding. That's a common finding. Now, estradiol imaging again. If there's a cancer, bad estradiol does not uptake. Hyperplastic, low-grade tumor, you can show very intense. There's a nodular here, enhanced mass is nodular. So mass is here, but only this portion is active, actively proliferating here by FTG. There's a whole tumor, but only this portion. There's a little bit uptake, but not much, but this is active. So they have to biopsy here and analyze the gene profile. Now, almost ready to finish. Oh my gosh, this time is up. There's a lot of other report sort of recently, and the Raman sort of scattering or whatever, so that the microvariant cancer can be visualized and that kind of thing. And certain neoadjuvant chemotherapy makes a remarkable, just incredible things. So it's a lot of new drug besides the platinum, Taxol, and then also we now have many sort of targeted therapy, particularly PAP. That's a gene that's quite effective. So that's called olaparib. That's a new drug to attack this PAP oncogene that combining with the EGFR inhibition makes a very successful control. And so usually combination of doxorubicin, very toxic, but the liposomal make it less toxic. And paclitaxel, and then this VGFR inhibition together. This is the thing. Okay. The genomic study has been now, and also now this immune therapy, PD-L1, using the pembrolizumab, has just tried, but they show it's the only little bit 1% show this PD-L1, and so but if this treated, it responded very well. So combining this kind of immune therapy and other chemotherapy are now going on, and certainly alpha sort of radioimmunotherapy has been also, see, actinium things or certain antibody labeled with actinium things is now on the trial. So I think we have to stop. Okay, again, I rushed the things, but if there's any question, you can direct me by email or Professor. So, okay, thank you very much.
So does anyone have questions or comments?
I'll just request if the professor can give us his comment about positron emission mammography.
Okay. Certainly, certain size tumor will take up FDG, but FDG is a non-specific, and also we are dealing with usually 1-2 millimeter microcalcification. Is just basically just a 1-2 millimeter size. So such a tiny lesion will not take up FDG. It may take up, but we don't see it. We cannot see it unless you image the whole day. So that's a limitation. So that certain localized brain or breast PET will show high resolution, certainly high resolution, but agent is not specific. If we have estradiol, maybe, using such a breast PET, it may be different, but nobody ever showed the data. So it's promising, but still, PET is still expensive and limited to certain large centers. So it's, because if we don't have the cheaper ultrasound, certain digital mammogram or tomo or MRI, then no question. But we have now many tools, very easily diagnosed. Then why we need expensive things with the same information? Because we have to have a gene profile by tissue assay. So just a tiny lesion, but the needling and then tissue assay. Therefore, we need just when nuclear medicine study seems to be more useful in advanced case or failed case to see the maybe therapeutic response and also distant metastasis. Okay, any others?
Is there any other questions or comments? Or if not, I think at that time
has been over. So on behalf of all the audience, I would like to thank Professor Kim for his lecture. And for audiences, I would like to inform that it will be thankful if you can fill out the questionnaires which I have linked in the chat box. And at there, you can also make a question. If you have any any further comments or questions, you can also put it in the questionnaires. Then we will give the reply in the next lecture series. So thank you again, Professor Edmund Kim. Thank you very much.
Okay, thank you. Bye-bye. See you next week.